Morning, my name is Claire Blake and I'm in Community Relations here at QIMR Berghofer, so I'm absolutely thrilled to have this opportunity. First of all, I'd like to acknowledge the traditional owners of the land of which we stand on, and also acknowledge the Yagara and the Turrbal people, and pay respect to the elders, both past, present and emerging. And we're just so thrilled you've taken up this opportunity to access some of the brightest and most experienced minds in the gut health and immunology. It takes guts. And this is all about you, and we're hoping that you'll take away something tangible, practical, and something to really help you navigate this pathway that you've been corralled into. So we know it's confusing, and hopefully you can take away something that you can use. And don't worry about taking notes today. This session is being recorded. We'll send you the link so you can revisit this at any time and go back over something you feel like you may want to listen to again. Now, let's introduce our special panel here this morning. We have lived experienced guests here. We have a PhD student here in Mucosal Immunology, Adrian Illich, and his mum, Thapar Illich, and they're going to tell us a little bit about their experience, and I'm sure that'll hit lots of bells for lots of people sitting in the room. And also I'd like to introduce our special distinguished guests and specialists today. We have Associate Professor Peter Lewandon in the green shirt there. He's a paediatric gastroenterologist, hepatologist at the Queensland Children's Hospital and the Foundation's senior staff eminent, and Professor Nikhil Thapar next to him in the pink shirt. Sorry, is it lilac? Director of Gastroenterology, Hepatology, and also Liver Transplant Service at Queensland Children's Hospital. And to the right of him is our very own Associate Professor Severine Navarro. She is the team head of Mucosal Immunology, which Adrian is a part of. And she's also the Director of Discovery at the Centre for Childhood Nutrition. And if I could just quickly talk to our specialist, and if you could perhaps, Peter, talk about what sort of questions you're happy fielding. I know that IBD is a specialist area of yours.
Sure. Yeah, my name is Peter Lewandon. I've been at the Children's Hospital now for 27 years. So
maybe a little closer, Peter.
Oh, sorry. Yes. Okay. I've been at the Children's Hospital now 27 years, and I've probably done most of the things that paediatric gastroenterologists do. But the last few years, I've honed down to inflammatory bowel disease, because inflammatory bowel disease has expanded to encompass more aspects of disease, illness and science than all gastroenterology used to 20 years ago. So as the knowledge, as you're hearing from our scientists, increases, the ability for clinicians to cover everything, understand everything, and try and stay up with the prevailing thoughts and science is getting increasingly harder. So my expertise is, as I say, in managing children with inflammatory bowel disease, and trying to understand some of the science that goes around all those decisions, some of the basic pathogenesis and the treatments.
Thank you. And Nikhil?
Yeah, hi, thanks, Claire. It's a real pleasure to be here. I guess if I was talking about my expertise, I'm a gastroenterologist, and I'm also a father of 3 children. I always thought as a pediatrician, I would be way ahead of the game as a parent. Then you realize that actually it doesn't help you at all. It actually probably makes it even more difficult. So listen, I'm happy to take any questions that relate to the gastrointestinal tract. My main area of interest is what we call kind of motility disorders or functional disorders. So children with reflux, abdominal pain, constipation, which really count as some of the most common symptoms that children suffer from. So happy to field any of those.
Yeah, if you're second guessing yourself about a question, don't, because this is the place to ask the question. You have the right people to answer, and there's nothing you haven't heard before, right, Peter and Nikhil? I've heard every question. And I know, right, like Severine, I know that you want to talk a little bit later about when you start the immune indication and things like that. What other questions, particularly research is your area, so what would you like to field questions on?
Yeah, good morning, everyone. It's a pleasure to be here. So I'm a mucosal immunologist, which means my area of interest is the immune system, and I'm particularly interested in when the immune system is not working, functioning properly, especially around the gut area, as well as the lung and the skin. We look at a various number of things, but we're mainly focusing our research on how to re-educate the immune system so it starts working naturally, normally again.
Thank you. Now, just before your questions, if you could pass that microphone to Palmer, please. Thank you, Nikhil. We're going to hear a little bit about lived experience. Now, Adrian is not coincidentally in mucosal immunology in the lab. It's something that started very early from him. Palmer, if you could tell us, when was the first time that you thought something was outside the norm of childhood illnesses?
So Adrian was born in 2000 in New Zealand, and around 6 weeks, he started to have some very mild rash on her face, but everything looked normal and perfect. And the doctor at the time said that's something related to hormonal growth in children and it will disappear, but it didn't disappear. And around 4 months, we gave him some formula because it looked like maybe that is not getting enough milk from breastfeeding. And we did it twice, and the second time he had a huge reaction, ended up in a hospital and found that he has huge allergy to milk. And after that, we found more allergies, and it was really difficult, and his eczema developed. So
how long was it before you got a diagnosis, and do you have one that you're satisfied with?
Okay, so when we, it was obvious that anaphylactic reaction was from milk because he was swollen. We ended up in a children's hospital in Auckland, but they couldn't really do any testing on a baby so young. So I think, did they say they told us we need to wait for, was it 9 months to do the full skin test? Because I think it was considered to be too risky to bring more allergens in a baby. So between 4 months and until he had first testing and confirmed all the allergies, I was told to keep off, just to breastfeed, keep off milk, eggs, soy, all nuts and everything, coffee, a number of other things. So I had reduced diet, and we went like that until he had the skin test, which then confirmed that he has a very extreme allergy to egg, quite bad allergy to milk, and medium allergy at the time to environment, dust mites.
So you would have had some pretty terrifying times because he was violently allergic, wasn't he? Anaphylactic, yeah.
It was just scared, like for the first 4 or 5 years of his life. It's constantly being scared, is he gonna survive? And, you know, making sure that you have EpiPen with you. And any little mistake, like he was so allergic to eggs, that even if I would mix the eggs in the same room or he's nearby, his face would go red. He had all this eczema, which we couldn't get rid of. And then all the mistakes, we go to the friend's place and everybody's really, really careful. And then he has a lolly, which has egg white in it. And then the pain in the stomach starts, you know, just kind of jelly lollies really with the white things have egg white. So at the time, so that was really like antihistamine could help in that case. Once he tried some of my pancakes when he was much older and I had to use EpiPen, there were things when my other son, who really liked milk and everything, would go around, or like always, he was also small, always keep away the milk from the baby. It's just that pressure on the family, where you are now appearing that you're paying more attention to one child than the other, thinking, how am I not gonna damage the other kid as well? And like if something happens, you already start yelling, don't go there. Then you realize that you really yelled too much on the other kid that is already too little.
And going to school, leaving him at school would have been quite a terrifying proposition.
School was interesting because at the time, so that would be year 2005, 6, 7, allergies are already prominent everywhere. So people would say, don't bring anything with peanuts, don't bring anything with nuts in school. And that was the direction. But, you know, it would be really hard to say, don't bring anything with milk and egg to school. So he would come home from school he would touch somebody's, or maybe somebody would leave a sandwich on the, I don't know how, but his eye would be closed and like swollen and closed, or he would touch something. It was much more, worrying, but the little kids, because he went through a few times through a pain of a sore tummy, if he tried something, it was quite actually
Painful,
disciplined,
yeah.
and careful.
That was enough to put him off. If we could talk to you, thank you, Palmer. A lot of people relating to that story, I'm sure. Adrian, when do you remember being aware of this? How young were you?
I mean, obviously, it's been around forever. So as long as I've had memories, I can remember, don't eat eggs and milk. That's very deeply ingrained in me.
So tell us a bit about how you remember your story and how you managed it as a child and how you navigated that, because it's a very tricky space.
Yeah, I guess, I don't know. I think I had such a great family and support. So it wasn't too scary for me. It was always like I knew someone else was going to be taking care of me if something went wrong. And yeah, because it was the only thing I knew, I guess. It was never something I thought too much about. It was just how it was, don't eat egg and milk.
And I know, having chatted to you before, that the diagnosis kind of changes and the responses change and the allergies change too. Tell us a little bit about that.
Yeah, it was interesting. And I'm very thankful that I was one of the those kids whose allergies kind of progressed in a way that they got less severe as I got older. So I'm very thankful for that. But then also as I got older, other things kind of popped up and some things would get worse, like my eczema, and then my eczema would go away. And I started developing asthma when I was a bit older as well. So I think dealing with these things, like kids can do that. Kids are, I think, stronger than people think. But the thing that is always really frustrating is when things are so out of your control. And I guess you can't really get a straight answer or understand why something is happening. And I think that's what really drove me then to want to do research, because, I don't want to just have to do, take an antihistamine or take an EpiPen. I want to fix it. I don't want to have allergies anymore.
You want to manage that before you have to deal with pain.
Yeah, exactly.
Thank you so much. Now we're opening up the floor for questions. We haven't got the audience mic'd, so if the specialist wouldn't mind just reframing the question for the recording session in their answer. Would anyone like to start with a question? You can ask questions of Adrian or Palmer or the specialist or Severine, anyone you like. Take advantage. I can start the questions. Just listening to Adrian here, either of the specialists, I know that he said he felt really protected when he went to school, but then as you navigate things as a teenager, there must be some sort of psychological part of these high allergy diseases that you see when you're treating them. You can't just treat them for the response, you treat them for lots of other things as well. Who would like to take that?
Yeah, thanks, Claire. I think, listen, I think knowledge and awareness of allergy is certainly better than it used to be. There was a time that people weren't so aware of it. And I think that's including specialists as well. And I think we are now in an era where we think about allergy. Of course, if we talk about Australia, then we're talking about one of the highest allergy rates in the world. It is a difficult space because the diagnosis of allergy is difficult as well. And although the kind of reaction that Adrian had is reasonably easy to test with the skin prick test, a lot of the allergies that we deal with, especially that relate to the gut, there isn't actually a test that you can perform to diagnose it. The skin prick tests are unreliable because the type of allergy is different. So therefore, unfortunately, it's a little bit primitive, but we are reliant on exclusion of a food to see if things get better and then a re-challenge to see if things get worse. Now, of course, you wouldn't do that if somebody's having an anaphylactic reaction.
Yeah.
You certainly wouldn't do that. But in terms of the impact, I think we are beginning to actually understand a lot more around the quality of life and the impact that children suffer. And that's not just across allergy, it's across all of the conditions we take care of. Unfortunately, we don't have a psychologist integrated into our team, but that's really what we're now beginning to work with, is to really understand that there's the disease, but but there's also the impact of the disease. There's an impact on children, there's an impact on families, and that impact is not just on psychology. There's a huge burden of cost as well. If you actually are allergic, going for a simple shop. In fact, in the UK, we did a study where we looked at the time to shop, and people with allergies were having to spend 2 to 3 times longer than anyone else to actually pick out the foods that they could prepare. It costs even more, et cetera, et cetera.
Yeah, it's stressful. Peter, would you like to talk about early intervention? I know there's avoidance and there's early exposure. Are those kind of directions changing now?
Oh, that's a complicated question. I'm probably not the best person to answer that one, because inflammatory bowel disease involves certain trying to understand all those early events and how that programs your immune responses. But you say in the field of allergy, that's all changing. Initially, it was about avoiding things to stop people having anaphylaxis and dying, and trying to follow a safe pathway. And then we discovered that by delaying all the introduction of things to when children are a bit more robust, that was actually encouraging or reducing the ability of the body to develop tolerance. And one of the key concepts of all immunological reactions and the human body to it is our ability to tolerate things. We're surrounded by bugs, we ingest them, we inhale them, we swallow them, we touch them. There are chemicals, there's proteins, there's viruses, there's bacteria, there's fungi, there's protozoans. And our body has to work out what is dangerous to us in terms of the substance, and work out what we have to eliminate. And our body has to then determine what we tolerate. And one of the things we're finding with allergy and with everything else is that a lot of the problems we get is our body doesn't recognize or tolerate a substance. So it finds a protein in dairy and bang, we've got to eliminate this and have a massive response. And of course, you get a disordered response and have trouble breathing, get covered in a rash. You have a food substance or a virus or a bacteria, and all of a sudden the body decides we've got to eradicate this, we've got to respond to it. So this whole issue about early childhood exposure has shifted from trying to be safe and avoid things which are going to make you unwell to, okay, well, how do we encourage the body to tolerate peanuts and dairy and rice and corn? The interesting thing is that in the Western or European world, the biggest allergen is dairy, because we all love milk and we have cows and we have cheese. In Latin America, the biggest allergy is corn, because they all have sweet corn and heaps and heaps of corn. And in the Asian world, the biggest allergen is rice, because they all like rice. So there are so many things we don't understand. But I say one of the key issues that's informing how we advise people early on in life in terms of feeding is trying to understand that issue of exposure to things so our body can tolerate them, but also avoiding things which our body is going to react to and make us feel unwell. And that's a really, really difficult topic. And it's very frustrating. It's very frustrating for families and parents who want some, advice that they can understand and they can follow and they can implement without completely wrecking their entire lives financially and socially and emotionally and cooking, trying to get that advice, but also being told, well, the advice isn't all that clear. Should I be having something? Should I be avoiding it? Should I be trying to encourage tolerance? Should I be trying to save my child's life? And it does get very confusing. You can't get a straight answer from a doctor often, because the doctor doesn't have a straight answer.
Well, Nikhil or Severine, would you like to weigh in on that?
Thank you. Peter is touching on a very important point, which is we know that allergies and sensitization, it's when your immune system is recognizing an allergen like pollen or house dust mite or milk proteins, like for example, like for Adrian. So the immune system recognizes this as a danger signal. And so we don't know when this exactly happens. We know that it happens very early on in life. And it's essentially the immune system really mistaking this as a danger signal. But what we find in the last few years, well, maybe decade, is that there's a very, very strong link between viral infections like RSV, which is it's a major respiratory virus in babies that often cause them to be hospitalized. It's what is also known as bronchiolitis. So lots of mucus. Some kids need to go into respiratory support. And so we have found that there's a very strong correlation between this virus and the development of food allergies and very severe allergic responses that lead to anaphylaxis. And so this is because the inflammatory event is so acute that there's a confusion of the immune system, and it starts to become primed against molecules that it shouldn't be primed against, like food antigens. So it's really hard to prevent, obviously. It's hard to manage. There's not much that you can do once a child is infected or hospitalized with RSV. But it is a very strong correlation that we have noticed in the past few years that link to the development, especially of food allergy, with a very acute response to allergens.
Thank you. Now, any questions? And obviously our specialists can't offer personal advice today. That's for someone with a complete medical record and the privacy of a consultation. But if you have a question, you have access to the leading edge researchers and clinicians. So anyone like to ask a question? Yes.
My question is just about finding the balance. Obviously, done all the skin prick tests and some, but most of them are, as you spoke about, the gastrointestinal ones at one point had over 12 allergens. We've got to the point that that's down, but then he'll get sick, or he'll have been exposed to one of his allergens or had a bit too much of something, and then it's just a storm, and it takes months for it to calm down. But then even when it's calm, we're half an hour on the toilet, that gastrointestinal signs are still there. And do we go right back to a very restrictive diet and he's comfortable and life is thriving, kitchen life is difficult, but everything's fine, but then nutritionally not complete, or having some of those potential allergens in smaller doses, but then there's the gastrointestinal side. And that's been our constant, that's been the hardest part in our life, trying to find that balance of no signs of allergy, but nutritionally not growing properly, or signs of allergy, emotional distress, anxiety, but growing. Yeah. Sorry, is that a question?
Can I offer just some maybe a bit of science behind this to maybe give you a rationale? So what's your name? Sorry? Chloe. So Chloe is talking about essentially trying to manage symptoms of allergy, I assume. And then when there's an accidental exposure, then it's a cascade of inflammation that will take months to resolve and leads to different symptoms, right? Some can be maybe skin, and then there's gut issues. And anyway, before it starts to calm down, it takes a long time. And there's, of course, nutritional aspects to consider with a growing child. So in terms of the science behind it, it's unfortunate, but it's very hard. I can't say that I think you'll find balance in the way that there are lots of things that we don't know about allergens, and it might be useful for you to read about what's called cross allergy. So you might be lucky enough to know which are some of the triggers for your child, but there are other molecules or other food sources that have some similar proteins that could also trigger these allergies. So it's a matter maybe of reading about some of these foods that are linked. And for example, and it's very, very difficult to manage because you might have house dust mite allergies, for example. And house dust mite, because it's a little bug that's co-evolved with crustaceans. So that means it's very likely that you'll develop food allergy later on with shrimp, prawns, crayfish, even lobster, because we can all afford it every weekend. But these are some things to consider, and vice versa. So if you have shellfish allergy, you might need to watch out for your house dust mite later on because it's quite likely that there'll be a trigger as well. So And in terms of the immune response to an allergen, it actually takes weeks and weeks and weeks for it to tame again. So unfortunately, there's no other way. The immune system will go back and forth in the tissues by waves. And they are activated. Some of these cells are called mast cells. They're activated for at least 3 weeks. So one exposure, you'll know you're in for a minimum of 3 weeks. But then you have all that irritation and inflammation that will probably induce some malabsorption into the food that you're trying to feed your child. So you'll have, it will take time to repair itself. So that's what you're talking about, that lasts a fair bit. But yeah, there are some foods that you could look into in terms of building the immune system and what Peter was saying regarding tolerance. But there's not, so orange foods are good, but it only depends if your child is not allergic to it. And it's not just, oh, eat carrots and you'll be saved. So by all means, don't take this. But yeah, there are some things that maybe you could look into, or it's just a matter of being patient.
Nikhil, anything to add to that?
Yeah, listen, I think you ask a very key question. And I think when we see children presenting with allergy, it's always a challenge because we want them to be nutritionally complete. And in fact, we are now, as people have moved on to much more restrictive diets, are seeing more children who present to us with malnutrition. All right. And the other big challenge is that as children get older, we're seeing more of the children developing eating disorders as a consequence of actually being very restrictive with diet. So we really do have a very important role in ensuring that doesn't happen. Now, a couple of things. One is a skin prick test tells you about sensitization. It doesn't tell you that you're necessarily going to have symptoms to something. So it's important to know. The gold standard for the diagnosis of allergy is actually a challenge with the food and then getting symptoms and then removal of that and not getting the symptoms going away. So that's really what, unfortunately, the gold standard at the moment. The second thing is that as opposed to what we used to think, it's often the form of the protein and the dose of it which is probably relevant. So if I say take cow's milk allergy, say you have a child and the child has a big reaction to drinking milk, how do you then proceed? So of course, there are possibilities that you can alter the way the protein is then given to the child. So what we would often do in order to prevent a big reaction from occurring again is to start down what we call a milk ladder. All right, because we know that if you bake protein, for example, it's subjected to a much higher heat and therefore it's denatured. So therefore the protein that's then presented to the body is in a different form. And now there's actually a good amount of data to show that one of the ways of inducing tolerance in children is don't go straight back to the milk, but to start to go down the ladder. And then you have a much greater likelihood, one, of not having a severe reaction, and secondly, starting to teach the body to tolerate that protein. So in fact, the big shift now in terms of early reintroduction after you've diagnosed an allergy is to reintroduce it, but use what we would call oral immunotherapy, where the protein form has actually been changed. So I think there are avenues now to say that we can start to think in a slightly different way in terms of reintroducing the protein.
Peter, I see you nodding.
Oh, yes. Look, I think, Chloe, although you were very modest in asking your question, I mean, that goes to the root of, I think, almost every parent of a child with gut troubles or with allergy troubles. And of course, the two are related because, you know, food intake and food exposure. And these are the most difficult conversations for both parents and doctors. And if I can be a little bit philosophical rather than factual, to me, it's just like being a parent. You know, you have a child and you want to do the best for them. And, you know, as they get older, they have certain behaviors, and many of those behaviors are predictable. You know, certain things will always make them happy, certain things will always make them sad. But most of their behaviors are completely unpredictable. You know, one day something will make them very happy and the same thing will only make them marginally happy, and the next day it'll make them miserable. You know, and another day something will make them a little bit miserable, or it'll make them catastrophically miserable, or it'll make them have a complete meltdown. And we know that allergy and food intolerances and the way the gut responds to all those things very much depends upon what's happening in the body at that time of the day. You know, what else is happening? How them, you know, are they in the middle of a virus? Are they post a virus? Have they had something else in their diet which is a trigger? What's the dose of what's in their diet? Even how they're feeling. I mean, the way we know about the gut-brain axis is more than just immunology. You know, our behaviors, our anticipations also affect our immunological responses and also respect our behavioral responses. And so as a parent of a child with all these, you know, gut issues, you know, you're trying to look for simple, you know, A plus B equals C. If I avoid this, or I do what the doctor tells me and add, you know, or the dietitian tells me, add a bit of this a little bit slowly, sometimes it works and sometimes it doesn't. So the frustration is huge, and the frustration is obviously the hugest for the parent because they're seeing that whatever they do, their child is still suffering, and it's very hard to convey that to the doctor because the doctor knows that your child is suffering, but they're also thinking, well, what do we say? Well, we can't put them in a bubble. You know, when I started pediatrics, you know, 30, 40 years ago, I was accustomed to seeing children inside big plastic bubbles. You know, mainly if they had no immunity, but sometimes if they had, you know, extreme anaphylactic reactions. Oh, we're saving their life. Great, but you're ruining their lives. You know, what kind of life is it to be inside a bubble and you can't touch anybody? And I'm even thinking, wow, you know, sometimes the intervention is worse than the condition. Of course, life and death doesn't get much worse than that. You've got to be alive, you know. And, you know, Adrian's story and Palmer's story is, you know, we do know that children die from anaphylactic shock all the time. One of the current tragedies of the Western world that children still die of anaphylaxis. So the terror is real. You know, you can't just say, oh, well, give it a try. You know, try a little bit of graded reintroduction. Well, it's all over. Well, what do you do? How do you find the happy medium? And if I can say anything today, it would be that I think there is a lot of sympathy in the scientific community and the medical community who also have their own children with exactly the same problems. But sometimes it feels like you just can't get a straight answer out of anybody because you do the right thing and then the wrong thing happens. Or, you know, and whose fault is that? Well, it is a bit life. Sorry.
Yeah, Adrian's nod. Yes. This is all familiar to you. I'm interested in the gut and the brain axis because I'm allergic to shellfish, but at a party recently, I was 40 minutes down the track. I already had shellfish and I didn't know about it and nothing happened. So is it psychological for me?
Well, I think it has a component. It's not the whole thing. I think what we have to realize is that our brain's anticipation of things is part of the picture. You know, I don't believe anyway that it's the whole story, but far from it. I don't think it's not of the story. It certainly changes the manifestation. Sometimes it has no difference whatsoever. You can be the happiest and most, you know, peaceful Zen person on the side of a Tibetan mountain. And if you have, you know, peanuts and you're allergic to peanuts, you're going to need your EpiPen, you know, no matter how Zen you are. But there's no doubt that if you're in a heightened state of arousal, either because you just had a, you know, a massive argument with your loved one, or you're just getting over COVID and you're feeling terrible, you get exposure then. It could be, you know, how you regard it, what your anticipation is, will change the manifestation. And that's the other reason for announcing that, is that doctors have been trained in this more recently, become so aware of the gut-brain axis that if they're talking to you, say, well, you know, what was happening at the time? You know, how were you feeling? What do you mean, how was I feeling? I had dairy and I had a reaction, you know. What do you mean, it's all in my brain? Well, of course, it's not in all of your brain. But there is an element to which I say our anticipation, our state of mind will change the manifestation of something. Not probably in a life and death way, but in terms of a quality of life way.
There's so many variables that parents here have to record, and listening to you, I just realized how complex their life is, you know, how they're feeling, if they had a virus, how they responded, and I know food diary is a thing, but what does effective communication look like for you as clinicians? If somebody comes to you, what is the best thing they can present with? Is it a total food diary? Is it an overall thing? What looks good for helping you help them?
So listen, I think it's teamwork, I think is essential. So what we've learned is when we come to a complex situation, we'd often work with our other allied health professionals like dietitians, who will then be able to work with families to get a better understanding of likely exposures and likely symptoms. So therefore, I mean, we have limitations. You know, you come to a clinic appointment, it's a pretty limited clinical appointment in terms of time.
Yeah.
So therefore, what we might actually do is to say, okay, I understand the basic problem, but what I now need to get is more information, a clearer amount of information to inform that. So often we then work with the dietitians to get that, to get that sort of information. I think the other thing, it's just important, coming back a little bit on the last point, is that we're talking about allergy here. Allergy is an immune-mediated reaction. However, in the population, there's lots of people that also have intolerances, all right, or do not have an immune-mediated reaction to the food, but the food for some other reason doesn't agree with their body. Maybe the digestion can't be complete. For example, if you talk about lactase deficiency, so people who are lactose intolerant, that's not an allergy. That's just an inability to break down the sugar. The reason I raise that is that a true allergy is present probably in children. We're talking across all of the age groups, somewhere between 5 and 10%. 10% in Australia is probably the highest recorded under the age of 1 at about 10%, but usually it's about 5%. However, in the general population, about 25% of people think they're actually allergic to something. So the rates of what people think they're allergic to is much higher. And that's because they eat a food that doesn't quite agree with them. And then they assume that that's what an allergy, but they are different things. So it's quite important to make that distinction.
Another question. Yes.
So, I'm coming out. My daughter's celiac, so she got diagnosed when she was 6. So we had a really easy process. Our doctor flipped it because he just wanted to exclude the diagnosis because she's largely asymptomatic. But my question is, her little brother, so he's coming up to the same age, is there anything we can do to support him so that way we can hopefully prevent his genes from triggering? Because both me and my husband both carry the genes, so there's a very, very high likelihood of inheriting that.
I'll just reframe that, just re-ask that question for the recording session, because unfortunately we don't have a microphone. So a celiac diagnosis and then a sibling coming up, how can she protect him?
So listen, that's if I knew the answer to that, I would probably be the most famous doctor on earth. So like any disease, we know that it's a multi-hit hypothesis that's likely to happen here, that you have a genetic susceptibility that, so in celiac disease, we know that 30% of the population is got the genes that may allow them to have celiac disease. But what the other hits are and what sequence they have to occur in order for you to get celiac disease, we don't really know. And that's true of celiac disease. It's true of inflammatory bowel disease. We're starting to get a sense of the kinds of things that might occur. But like Peter said, is if we started to know that and we knew that it was a viral infection, then what would that mean to your day-to-day life? Would it mean that you would never go out and you'd never get exposed? So it's a tricky thing. So at this moment in time, the clear answer is that we do not know what, even in a genetically susceptible person, makes them get celiac disease. We know that we need to be a lot more aware, because celiac disease doesn't necessarily present, as you well know, I'm sure, with the classical diarrhea and whatever. It can present in anyone with any kind of symptoms across the body at all. So what we'd often say is that if there is a family history of celiac disease, we have a much lower threshold for thinking about it. And in fact, it's probably one of the most common tests that we do worldwide at the moment is a screen for celiac disease. And it's important to know that that screen is not looking at the genetics. The genetics by itself does not tell you you've got celiac or you're going to get celiac disease at all. Yeah, there's a different serology test called a tissue transglutaminase. That's the test which tells us you got celiac, because we get so many referrals saying, I've got the gene and I've got a symptom, but that doesn't mean you got celiac disease. Pete, I don't know if you want to add.
Oh, no, I agree with exactly that. It is a challenge. Prevention is the holy grail for almost any condition. And you'd think that with celiac disease being, was it 1 in 80 Caucasians, and the gene carried in 30-odd% of Caucasians, you'd think that we'd be a bit further down that route. But it is very complicated. It's a very good question. I suspect, in your little one's lifetime, there will be a lot better answer, but it's not imminent.
It's interesting that you say, it was just a fluke and we were lucky to get a diagnosis. It's sometimes a long path to get down there. And for somebody who's just maybe like Palmer and has a little baby and is having these different sort of responses, how do you as a person decide which specialist to choose or who to go to and to get the sort of results that you can manage?
Ask me.
Yeah.
We had no idea about anything, and allergy was quite, it wasn't that big thing then. So we just did whatever doctors told us in emergency and went to see immunologist and dietitian. We got special formula for Adrian and all that. But I just want to highlight, at the time they asked, what allergies do you have? What allergies do you have in family? And we only knew that we have hay fever on my husband's side, and that he had some eczema when he was working with some metals. And then, because Adrian was diagnosed and Jacob was 40, he was having all kinds of strange symptoms, like exploring, like they thought he has a heart issue, had a funny feeling in his brain. And then it turned out that he has a celiac disease.
Oh.
And that's how we discovered when he was 40, actually, that he started saying, oh, maybe it's an allergy. Maybe I don't need to go to see all these other specialists. And it turned out to be that, yeah.
It is tricky to navigate. Would either of the specialists like to say, how do you choose where to go? Or is that your primary care physician should be able to direct you in the right space?
I think this is a good opportunity to, again, sort of set a bit of an agenda. Lots of times people want to come straight to the main person, tell me what's going on. But because of the complexity, you really do want to, I know it can be very cumbersome, you really do want to start through the generalist. The generalist who takes the overall picture, that's your GP, or if you've gone the next step to a general paediatrician. Because one of the problems about honing into a specialist early on, which is a major problem in the US, is that if you pick the wrong one, the specialists are trained to think about their specialist training. So if you come to a gastroenterologist, you're likely to get an endoscopy. If you go to a respiratory doctor, you're likely to get a bronchoscopy. If you go to an infectious disease doctor, you're going to get a whole range of infectious disease tests. If you go to a heart doctor, you get an ECG. So people do what they do well. And there's a presupposition that when you come to that specialist, you're coming because you've already been defined to have a problem. Now, of course, if you're having anaphylaxis and, needing an EpiPen, well, it's pretty straightforward that you need an allergist. And I mean, your story is just how extreme and how sensitive a human being can be to the environment, and all the different food proteins that are in the environment. And I mean, that's terrifying. When someone's trying to deal with that, the question is, how do you deal with that and have a quality of life? But for almost every other setting, if you don't have a clear anaphylactic allergy where you have an instant reaction to something, it's very wise to start off as general as possible so that the whole picture is looked at. Is it celiac disease? Is it allergy? Is it something else?
And I guess the specialist has responsibility of care to rule things out if you've come to them with an endoscopy or
well, they do, but we're
bronchoscopy.
not going to be very good at ruling it. If you're a gastroenterologist, you're not going to be very good at ruling out. You should be. I mean, we are trained in everything. You're called a subspecialist for a reason. As you start off, being a doctor, then you become a paediatrician, then you become a pediatric gastroenterologist. So you're honing into one specialty. But if you come to me, I've been doing pediatric gastroenterology for 30 years. I mean, my up-to-dateness with anything that's outside the gastroenterological tract, is very diminishing by the year. So it can be cumbersome to get your GP referral to your paediatrician, then your GP refers you to the specialist. The specialist says, well, I've got a general paediatrician because I want to know that there's a holistic thinking process. We like to think that everyone's treated in a holistic manner, which is the holy grail. But the reality is you really want people to be at least be thinking holistically before you go down a subspecialty route.
Do we have another question? Yes.
question that probiotics and prebiotics, studying research that she made that the facts that I get
Thanks, Pete, for subtly passing me the microphone.
So the question's about prebiotics and
No, no.
probiotics,
Yeah,
EOE and SIDA.
So listen, I think it's a great and very topical question, and there's a lot of attention on how we can manipulate these bugs within the body, because we know that they form an essential part of what we call the microbiota gut-brain axis. And we know that there's so many diseases, and in fact, even down to inflammatory bowel disease, we know that there's a disruption of that, which is likely to be at the root of many conditions. And these aren't even within the gut. We're talking about even rheumatological conditions like arthritis, et cetera, et cetera. So at this moment in time, there is a lot of data out there in terms of what probiotics and prebiotics might be able to do. There is some good data to suggest that they may be able to control some amount of symptoms, but at this moment in time, there's very little data to suggest that they will stop a condition from occurring. We do know that disrupting the microbiota in early life, for example, the use of antibiotics in children in very early life, can have lifelong consequences. And there is now good data to show that. And even things like acid suppression. So unfortunately, a lot of children with reflux, they still get dished out acid suppressants all the time. We do know that there are consequences of long-term use of acid suppressants on bugs, for example. So therefore, at this moment in time, although we know that disruption of these bugs does have is a potential contributor to disease, we haven't got a very easy way of manipulating it. All right. Now, of course, some people have gone to the extreme and even do fecal microbiota transplantation in an effort to really fix things, and there's reports that dramatic changes have happened. I don't think we have enough data. The problem is doing good studies that are really robust and you can challenge them. Unfortunately, there's little studies to say, oh yeah, we gave a few people the probiotic, they got a little bit better, or so I think the answer at this moment in time is no. And I think a lot of it comes back down even to the original question about a healthy, balanced diet. Unfortunately, celiac disease, I suspect that in the case of your children, did affect bone health as well, and that was probably the contributor to the fractures. And I think it also comes down to education. So although, as Pete rightly said, we can't see everyone as a specialist, however, we can help in the education of all professionals. It's kind of why we're here in a way as well. It's about being able to inform the general public, raise awareness, ensure that general practitioners have information as well, that they're thinking about these things as well. So we do have a duty of care in terms of providing education. In terms of celiac disease, what we're currently doing, just so you're aware, at Queensland Health, is that we're trying to move towards developing what we loosely call a celiac passport. And that is something that families will carry to ensure that they get the same care, irrespective where they live in Queensland, and into what needs to get done, what should they be thinking about. So that's something that we will be working with families as well to try and develop.
You adding to that?
Oh, I know. Look, I do. I agree with everything. Oh, obviously, everything that Nikhil says. He's my director. So, but no, look, the first thing to say is that there is a lot of information, and I think we have to realise that parents do everything they can for their children. What's coming out now that there may be acid suppression, things you've heard by the counter ranitidine, that's an H2 receptor blocker, or omeprazoles, which is the proton pump inhibitors, but everyone seems to be taking for reflux. We now discover perhaps it's not such a good idea for your microbiome, but you have to understand that so many parents are giving their children these medicines because when your kid's screaming and we're going through the night and you can't get any sleep, you'll do anything just to help them and to help the rest of the family. So having taken a PPI is not going to make a child desperately unwell. It's just if you compare 1,000 people who have taken them, 1,000 people who haven't, maybe some of these problems are a little bit more common in the people who have taken them, not because it's a poison. And the same with antibiotics and stuff. The issue is that in many cases, you don't give antibiotics just for the sake of it. You know, it's not a tonic. You know, it's because your child's unwell, has got a high temperature. And we're all programmed to think that maybe if it's, you know, something serious like meningitis, or if it's, you know, an ear infection which gets into your bloodstream, or it's a skin infection which gets into your bloodstream and gives you septicemia, you know, those are the kind of things that everyone's worried about, including your doctor. So if you've had some or given your child some antibiotics in the first year of life, yes, that does appear on all the multiple studies of you know, predisposing factors and stimulating factors, you know, it's in there, but it's a small but significant contributor. But you know, if you're giving your kids antibiotics, it happens. You know, my kids had enormous amounts of antibiotics because, of course, every time they got an infection, you know, they had parents that were very closely allied to the medical community, and thankfully, the pair of them haven't developed major allergies and inflammatory bowel disease. But in answer to your question about probiotics, we have to remember that, you know, after about a year of life, your microbiome is pretty solid. It's very hard to change it, you know, unless you get something, you know, well, if you get celiac disease, for example, and you treat your celiac disease, that'll change your microbiome. If you have antibiotics, that'll change your microbiome for a few months, then it always wants to go back. So if you're going to be taking probiotics, you take them for the rest of your life, or the rest of the time that you're, you know, concerned about this issue, because your body will always want to go back to the microbiome that you've established in the first year of life, depending on whether you were born by cesarean or by vaginal delivery, whether you're breastfed or whether you're bottle fed, how long you breastfed for, and what kind of solids you're exposed to, and all that kind of stuff. But by the time you're about a year of age, your microbiome is fixed, which is why fecal microbiota transplant or probiotics or prebiotics really only have a limited role, because as soon as you stop taking them, your body will take you back to that microbiota that you had previously. And it is very hard to work out what the best probiotic is for one particular individual, because we've all got different influences on the way our body's behaving and the other things that's in our diet. And again, whether we have COVID or we have this, it's all going to change things temporarily, and going to influence whether at that moment in time that probiotic is helping. So the good news is that in most cases, unless you're talking about pancreatic cancer, in most cases, probiotics aren't going to do you too much harm. In some cases it can, but also in most cases it's not going to be the major difference. The one time where we do use it medically is when, for example, children with cystic fibrosis have a lot of antibiotics, and we do find that if they get probiotics, they recover their normal microbiome or their abnormal, their usual microbiome more quickly if they're on probiotics, and therefore stop their post-antibiotic diarrhea more quickly if they have a probiotic after their antibiotic. So there are certain circumstances where it's very useful. In the main, it's probably not as good as we'd like it to be.
Severine, you wanted to add something?
Yeah, Peter was touching on a very interesting point, which is it's quite difficult to get the information about which probiotic to use if you had to use one. And from what we know nowadays about the microbiome, we know that it's important on the major question is about how it works, how it helps your body function properly. But we are not there yet to tell you exactly what's essential, especially it might be essential for you, but it may not be working the same way for me, for example. But in terms of a healthy microbiome at this point, the only thing that we seem to converge is that we need a very diverse microbiome. And the best way to achieve it, of course, is with a good, varied diet. But with certain conditions like celiac, of course, that would be quite difficult to achieve, although you could still have, you know, fruits and vegetables and different fruits and vegetables. But I would say if you were very intent on exploring the probiotics area, I would say the best thing probably to look for is a probiotic cocktail with many different species in it, not one where you have just bifidobacterium and just one particular species, because it's just going to essentially make like a weed, you know, like growing that particular bacteria within the gut and displacing the other ones, where it might make it difficult for others to come in or remain. And in terms of prebiotics, I don't know if the room is quite aware, is essentially the compounds that could make these bacteria grow. It's almost like fertilizer for your bacteria. So you have to think about it in terms of, I don't know, feeding cattle. If you don't have cattle, you can give cattle food, but they're not gonna eat it, right? So your prebiotics will only be relevant if you already have the species of bacteria in there. I firmly believe that it's a better strategy rather than probiotics myself, but that comes from a person who would already have a fairly healthy gut, a healthy balanced diet, lots of variety. Then it would probably foster the good stuff, especially when you have to take antibiotics or you have COVID, it might make you bounce back a bit quicker. But if your microbiome is already imbalanced or struggling, you could give whatever food to it. If the bacteria aren't there already, you're wasting your money. So again, diverse food is the best way to go if possible. Varied things, different colored foods. But again, if you had to go with the probiotics, definitely look for things that have 100 plus, I don't know if that's possible, at least more than 2 or 3 species in there to make sure there's already a variety in there.
I can see a couple of aisles of the chemist disappearing slowly in front of our eyes. You had another question right at the back. Yes. Can you hear that? Not diagnosed with a wheat intolerance, but it's obvious that that is the case. Would you introduce tiny little bits or avoid it? Is that right?
Look, look, that's a very, again, an important question and a common one. And everyone has a slightly different take on it depending where they're coming from. Obviously, wheat contains gluten. So, you know, there's a celiac question there, and many doctors go straight to the, it's a lifelong condition, you need to avoid it for that reason. Wheat is also a protein, so you can be allergic to it and have, you know, an allergic reaction come out in rashes or have an impact on gut motility or other things in your system. But also wheat is, you know, contained in fiber and gives certain fermentation characteristics. And you'll know that wheat avoidance is very important for people who have you know, gut problems and part of the FODMAP diet. You know, avoiding gas-producing healthy foods, you know, which are high in fiber, produce a lot of gas, which most people just fart out. But people who have got a sensitive gut because of a previous injury, a little bit of distension of their gut with a bit of gas gives them pain and distension and misery. And that's not celiac disease, that's not allergy, that's just the fermentation characteristics of wheat, along with your gut being a bit sensitive to the extra gas that's being produced. So the how to best treat it really depends upon, you know, which of those 3 components you have. You know, I suspect if it was Adrian, I'd be wondering if he was anaphylactic to it or allergic to it, you know. If we're in the celiac clinic, you'd be wondering if it's celiac disease. And if you're in the motility clinic, you're thinking, well, you know, have you got a motility disorder because of the gas that's being produced, which is either speeding up your bowel, slowing down your bowel, or just giving you pain? So in answer to your question, it's about, if you've got celiac disease, no gluten, no wheat is good. If you've got allergy, well, you can probably tolerate a little bit more depending on what precipitates the allergic responses. And if you've got the intolerance with all the pain and the misery and change in your bowel, it's however much you can take to not reproduce those symptoms. Sorry, did I get your question?
So would that, we got a negative result, would you recommend retesting that?
I think this is getting down a very narrow path, and our specialist can stay for 5 minutes afterwards. Maybe you can have a chat, or would you like?
I'm happy to answer that, because it's
Okay.
a very common question, you know, that gets posed to us. And of course, we get referrals where this person has got some troubles and they got a negative celiac test, and it's kind of, well, were they on gluten at the time, or were they on enough gluten at the time, or do they have IgA deficiency, which is a common but not completely rare condition where your body doesn't make quite enough of the antibody which is being tested to see if you've got extra of it. The answer is really up to you. A gluten-free diet is an impost, but it's not completely unhealthy. To exclude celiac disease, sorry, you need, to treat celiac disease, you need to be off gluten completely. So a little bit of accidental here and there, probably is enough if you're negative to say that you don't have celiac disease. But if you were conscientiously as a family avoiding all gluten because members of the family were gluten intolerant and it was a fairly rigid diet, well, then you're quite right. You can't be sure if you're actually treating the celiac disease as well as everything else. Now, some people would say, yeah, well, when we're on gluten, we feel terrible. Do I really have to have this challenge because I know that Bobby or whoever is going to feel terrible? We say, well, don't make him feel terrible. Keep following the diet if it's not too onerous, and test him when you're ready, to take the consequences of any symptomatic misery that may or may not go with it. But in terms of your peace of mind, you really can't be sure that he doesn't have celiac disease unless he has a test at a time when he was being exposed. And that's the same answer we give to anybody. You really need to be having some gluten at the time of the test to reliably exclude celiac disease as a cause of the symptoms.
I wanted to add to this in terms of course, the science behind it. With complete avoidance of a particular trigger, there's pros and cons, I'm sure you're aware. And so in terms of the allergy side of things, of course, if there's anaphylaxis or very violent response, you want complete avoidance. But then comes the risk of accidental exposure and what happens then. But that's something else to manage. When you're looking at avoidance of an allergen just to prevent symptoms from happening or even as a preventative measure, then that's a bit risky, because the reason why you want to avoid exposure to a particular compound or protein or substance is because the repeated inflammation that you get in the tissue, so the gut, for example, if it's gluten, will eventually damage it, erode it, and make the disease more severe. So, and it's the same for asthma or any type of allergy. So that's why you would like to prevent these episodes from happening, because you may make the disease progress that much quicker and more severely. However, in terms of allergy treatment, the only thing that is currently available is you must have heard of desensitization, which is a very small exposure to the allergen in question. And then you eventually increase it progressively, very, very slowly. It's so you can build what Peter said is what we can build tolerance and increase the threshold essentially of responding to it. So it has a beneficial aspect in terms of accidental exposure. Now, you will not have as severe symptoms when you get accidentally exposed to it. But in terms of gluten, for example, you can also maintain a certain level of tolerance rather than being fully reactive at minimal amount of exposure. So if, first, of course, definitely, ideally, having a diagnosis is helpful. But if it's not fully confirmed, then teeny amount of gluten to make sure is maintained until you know for sure would be the safest approach. Because if you fully eradicate it, you may have a bigger adverse event in the case of exposure later. But again, make sure your GP, everybody, so it's not an advice I'm giving you, it's just the science behind it. What we want to achieve when we have an allergen or a molecule that's causing immune activation is to build that tolerance against it.
I think we've got time for one more question. Our panel has agreed to stay around for about 10 minutes afterwards. We'll enjoy coffee and morning tea on us, but I know you've been waiting to ask a question. Yep. If you could speak up.
I got stuck on your point about long-term use of acid suppressants for reflux that can have long-term life impacts. I had two children with severe reflux, and then Peter was kind enough to care for my eldest son, Hugh, with his inflammatory bowel disease. And I just wondered, you know, like, tasting nearly grandmother status, I'm hoping we can do a bit of a do-over. We learned from our previous, you know, is there any research? I guess the short answer to that question is there any research that is going to help us manage severe reflux that doesn't have lifelong?
Any recent research that will help us avoid the lifelong complications of having acid reflux?
So listen, I think it's important to put everything in context, like Pete did allude to earlier on. So part of the pushback against proton pump inhibitors came from their use in infant regurgitation. All right, so all of you have had children, they posit, they have reflux, it's a physiological thing. It's part of normal development, and some of the kids do get a little bit irritable with it. But there was a huge surge in the use in infants on the use of acid suppressants, and almost an exponential rise. And in that group, there was certainly evidence in the longer term of issues around allergy development, infections, et cetera, et cetera. I think if you have reflux that is damaging the esophagus and there's evidence of reflux esophagitis, then there is a good place, a very effective place for the use of proton pump inhibitors. So I guess it's always a balance. And a clinician has got to make that decision around the balance of it. What we'd often say is that even when we do use it, that we would often look to come off it at some point to see whether it's actually necessary, because children are growing, they can often outgrow some of the issues that they have. But there is a definite place for the use of proton pump inhibitors for children who get erosive esophagitis, who are very symptomatic, who might actually run the risk of sending refluxate higher up and getting even lung problems and things. But it's just about a balance. I think what we, as a medical specialty, is pushing back against just the kind of use indiscriminately in children to say, oh, you've got a bit of reflux, try a proton pump inhibitor. And the important thing about that is that it suppresses the acid. It doesn't stop what comes up. So the reflux still happens, it just makes it less acidic. So I think, I mean, looking back, we are beginning to learn about, you know, indications, because you can't do an endoscopy on everyone to know whether they've got erosive esophagitis. So there has to be a call that you would have to make. And then sometimes we will say, okay, try this acid suppressant and let's have a look at your symptoms when you come back to make a decision of whether they need to go on for a long time. I don't know if that answers your question.
You know, nice to think that there is research going on that you don't need anyway.
So, I mean, I think a lot of the symptoms, a lot of what we talk about, unfortunately, as gastroenterologists, are symptoms. We talk about constipation, we talk about reflux. It's a bit like going to see your respiratory specialist because you had a cough. So a lot of the research now is directed as the cause, not at the symptom. So, for example, if you have constipation, it's understanding why do you have constipation? Is it because you have a kind of allergic response within the gut, which has slowed the gut down, and that's why the symptom is presented. So a lot of the research is now directed towards the cause, not the symptom. And we're trying to push people away from just simply treating the symptom without actually understanding what the cause is. So therefore, for example, we know that if we talk about allergy, we know that infants can present with severe reflux because they have an allergy. The answer is to treat the allergy, not to give a proton pump inhibitor, because that's not going to actually deal with the cause. So it's really, the research now is directed towards the cause.
Incredibly. Oh, go ahead, Peter.
Oh, no,
He's just
it's lovely to
sliding the
see
mic over.
I thought I recognised you, but I couldn't place that close. Look, the problem is reflux is ascribed to the cause of problems, you know, all around the world. And one of the reasons there's so much information about the you know, potential effects or potential adverse effects of PPIs is because so many people receive them. You know, it's one of the most prescribed medicines in the Western world, probably more than 50% of people over 70 are taking them. And at one stage, 1 in 5 infants in the US was taking them. So there's data points on millions of children. Therefore, when people are doing big data analyses of what causes cancer, what we got our best data on, you got it on PPIs. And so I think we can all agree that maybe it didn't live up to the promise we wanted. It was, trying to relieve all the screaming kids who are regurgitating everywhere. There is millions of data points about potential cancers and osteoporosis in the future, but really it's not that bad a drug. Not that I'm a defender of the company. No one's paying me to say this, but obviously you have to have a right balance. But one of the problems with reflux is that everyone does it, and why is it that some people, get problems from it and other people don't? If your average infant, reflux is 80 to 90 times per day and your average adult, 20 to 30 times a day, why is it that some of them seem to get some misery or some heartburn and others don't? And of course, when that misery is extreme, you want to do something about it. And then, of course, what happens is, you go from treating the kiddie that's screaming 24 hours a day and trying to make a difference to, even the kiddie that's screaming for half hour a day, someone's decided that means there must be something terrible going on. So you treat more and more people. I think the reality is I don't think there's going to be a cure for reflux because it's a necessary physiological phenomenon to get rid of pressure from our stomachs when we're eating food and swallowing lots of air. So you want to be very careful with messing with it. There are more neurons and synapses around your lower esophageal sphincter than almost anywhere else in your body, including your most otherwise sensitive parts of your body. So messing with that is very difficult. So I don't think there's going to be too many answers to your questions in terms of a better science of managing it or managing the symptoms of it, simply because it's kind of part of our existence and it's very hard to separate symptoms attributable to reflux or everything else that's happening at the same time.
A special thanks to the Australian Society of Immunology and also the Queensland Immunology Research Centre who allowed us to host this today. It's been incredibly informative. I'm sure we could keep you here all day. We would like to thank you. Join us for morning tea. Special thanks to our lived experience guests, Adrian and his mum, Palmer, and also our 3 associate professors, Peter Lewandon, Nikhil, Thapar, and Severine Navarro. Thank you all so much. Please join us for coffee and tea and a 10-minute chat. Thank you so much for your great questions. And lots more resources with our websites, podcasts, anything you'd like to know. And we also have a donation station if you'd like to be a part, supporting our research and Severine's research and all the research at QIMR Berghofer. Thank you.